Welcome to PIPADOR Revise in 5, a series of short, focused revision tutorials for MRCOG. This tutorial is on the topic of ovarian torsion and makes reference to the recent TOG article published in June 2025. Ovarian torsion is defined as the rotation of the ovary plus or minus the fallopian tube around the infundibulopelvic ligament and the utero-ovarian ligament, also known as the suspensory ligament. This causes initially venous and lymphatic obstruction and eventually progresses to arterial compromise with infarction of the ovary. In terms of the epidemiology, ovarian torsion represents 2 to 3% of gynecological emergencies and is the fifth most common cause of emergency gynecological surgery. The peak incidence occurs in women of reproductive age between the ages of 29 and 34 years old, but it can also occur in pregnancy, typically between 10 to 17 weeks gestation, although it can occur at any point in pregnancy and postpartum, and it can also more rarely occur post-menopause. Risk factors include ovarian cysts, particularly dermoid cysts, any cause for enlarged ovaries such as polycystic ovarian syndrome or assisted reproductive technology such as IVF, tubal sterilization, which actually carries the highest relative risk, as well as prior torsion and pregnancy. The clinical presentation may include symptoms of sudden onset severe unilateral pelvic pain and sometimes with nausea and vomiting in up to 41%. The signs can include unilateral adnexal tenderness plus or minus a palpable mass. The differential diagnoses include ectopic pregnancy, appendicitis, a ruptured ovarian cyst, and pelvic inflammatory disease. A pregnancy test is essential in all women of reproductive age. Ultrasound is the first-line investigation, and this could show an enlarged ovary, typically over 4 centimeters. There may be peripheral follicles and stromal ovarian edema. There may be free pelvic fluid. The whirlpool sign represents a twisted vascular pedicle and carries the highest positive predictive value for ovarian torsion. Color Doppler may show loss of venous flow or arterial flow, but it's important to remember normal flow does not exclude torsion. MRI can be considered as an adjunct if the diagnosis is unclear or if there is pregnancy. CT is not routine. However, the definitive diagnosis is surgical visualization at laparoscopy. The management of ovarian torsion is urgent laparoscopy as it is considered a surgical emergency. The preferred approach is to aim for detorsion plus or minus cystectomy if there is an underlying ovarian cyst. The ovary should be preserved even if dusky and hemorrhagic in appearance, as there is typically dual blood supply and recovery is often possible. Oophorectomy should only be performed if the ovary is necrotic. If the woman is postmenopausal, unilateral salpingo-oophorectomy is recommended. The recurrence risk for ovarian torsion is around 60% if the ovary appears normal at the initial presentation with torsion. The risk of recurrence is around 5% if an ovarian cyst is left in situ awaiting an interval cystectomy procedure. Oophoropexy should be considered in recurrent cases. Patients can be reassured that fertility is likely to recover after detorsion in most cases. The malignancy risk for premenopausal women is between 1 to 2%, whereas for postmenopausal women, the malignancy risk is quoted as between 15 and 20%, and oophorectomy and histology should be considered. It is safe to perform laparoscopy in pregnancy with standard precautions, and detorsion is preferred in these cases. Key points to remember for the MRCOG. It's important to maintain a high index of suspicion as the presentation may be non-specific. Vomiting is a clue in question stems. The whirlpool sign carries the highest positive predictive value for torsion on ultrasound. Detorsion should be attempted first, as even dusky ovaries may recover. Tubal sterilization carries the highest relative risk. Learn the rates of recurrence and when to offer oophoropexy. In postmenopausal patients, the malignancy risk is up to 20%. Here is a sample EMQ question from our online MRCOG Part 2 revision question bank. If you would like to test your knowledge further, you can subscribe to this on our website pipador.co.uk.